Good morning, ladies and gentlemen. We are about to start with our weekly media briefing. Today, the briefing will be led by the Premier, and the MECs are also here. The Acting MEC for Health, Jacob Mamabulo, and the MEC for Education, Panyaza Lisufi, and Dr. Mary Kawonga, on the left of the Premier, that side. She is one of the advisors, or she heads the advisory panel. So it's a team of professors and experts who have been working with us right through as we started with the response for the pandemic. Then we also have Professor Lukele, the head of the Department of Health. I'm going to ask the Premier to come and open. So today we are going to do our briefing slightly differently. So the Premier will not do the entire presentation that we used to do all the other weeks. He will make his opening remarks and then invite some of the experts to come and present some insights. There will be 3 main presentations actually, which will anchor our briefing today. But for now, I will ask the Premier to come and give his opening remarks, after which we will start with the presentations.
Good morning, ladies and gentlemen. Dumelang, Badudi ba Gauteng. This morning, we are doing our weekly media briefing, which we have stuck to throughout this period without failure. There are days on which we do it on Thursdays, and on other days we do it on Fridays. But we want to make sure that we keep the people of our province informed about the work that the various sectors of society are doing, and we also want to keep members of the public informed around any new trends, messages, observations that we have made that needs to be communicated to the public so that we fight this pandemic together. I think the main thing is that the only way we can win this battle against COVID-19 is if everyone, as many people as possible, must be given information, and government must share information with the public. We must be able to share information with members of the public. We must be able to communicate where the pandemic is going, so that communities in those areas themselves are informed, are aware. Also, where we have hotspots that are hitting the roof, we want to inform members of those communities so they can take extra measures. And also when there are positive developments with regard to a decline or decrease in the number of infections, we also want to be able to communicate that. We also want to share insights about what's happening in our hospitals from our clinicians. So we do have a team of clinicians today that will also share some information. But the main focus of today's briefing is that the pandemic, the COVID-19 pandemic in Gauteng province is entering a new period. We have said over a long time that just when we were doing well in May, we had said it's going to be very tough ahead. We are going to go through winter. It's going to be very very challenging if you combine COVID-19 as a new pandemic with what we normally experience during winter. We know that during June, July, we went through one of the worst periods. During June, July, in terms of the number of infections, there was a period that we had 6,000 infections a day. That's daily infections. We hit the roof at that time. And also the number of fatalities, the people who succumbed to COVID-19, that number shot up quite dramatically. We are now in August. We are still going through the storm of COVID. We said at the beginning of June, COVID-19 has arrived. That storm has arrived in Gauteng. It's going to be biting. We're seeing some positive developments in terms of the reductions, but we want to still say the road ahead is still long. We use science to come at those conclusions. We don't just, not just a feel-good thing, but we also continue to observe what is it that people are doing better when our people are not responding well on the measures that they must do. We also say people are not complying, but when there are improvements, we must also give people feedback. When there are improvements, there's compliance is improving, we must also give people feedback, only to say to them, continue doing that. And also when the provincial government has adopted new strategies, given the nature of the pandemic, we should share it with the people of our province. So yesterday, we had the Gauteng Executive Council, that is otherwise known as the Provincial Cabinet. The Provincial Cabinet met yesterday, invited at its meeting the groups of scientists, researchers, including the clinicians who are in the cold phase of this pandemic, and the technical experts on infrastructure who gave us useful insights in, given where the pandemic is now, how do we plan ahead? And how are things going to look like from a modeling point of view? How are things going to look like the road ahead? And what type of response is required? Because COVID-19 is a new disease, so we must always adapt our plans. If after 2 months there's new observations and new insights, even if it's to observe what has happened in the Western Cape, what has happened in the Eastern Cape, we must draw those lessons, or what has happened elsewhere in the world. We must draw those lessons and adapt our plan. So we are in a permanent state of adapting our response. We can't fix what we adopted in March. We must continue to adapt as the situation changes, and as the scientists bring new information, we must continue to adapt so that we give the best shot, the best response to save more life. Our preoccupation is principally about saving more life, reducing the number of infections, treating those who are infected and the sick, having adequate capacity to provide for those who are sick, but also isolating and quarantining those who are infected. So as I say, that strategy will continue to be adapted as we move from one phase to another and as new developments emerge. So we often start with, so what is the trajectory of the pandemic now? What are the predictions from the modeling team? The Provincial Advisory Committee has looked at what is happening, and they are going to first share with us what, according to the modeling, what is likely to be the trajectory and the progression of the pandemic and the evolution of the pandemic going forward. So we have the advisory committee that is chaired by Dr. Mary Kaonga. So Dr. Mary Kaonga is going to introduce what the modeling team has done, and then together with Dr. Mary Kaonga, Professor Melado will then take us through. We want the people of our province to be at the same level with us to understand. Are they observing the same issues? Should we be celebrating, or should we be cautious, or should we be completely be lowering the guard? This information must be shared. So where are the signposts that need to be watched? Where are the blind spots? Where are we sure of what the information, but where is it tentative? And then the modeling team will also be followed by another important institution in our province, the Gauteng City Region Observatory, about the dynamics of this pandemic in various communities. So they will complement each other there to give us a full sense of how is COVID-19 manifesting itself in Gauteng. It's not necessarily manifesting itself in the same way as in other provinces. And here, given the nature of our province, how should we be responding to that? And that's where there will be the other set of presentations now from the clinical team that will be able to say the best way and most comprehensive way to respond to COVID-19 in our province must be this way. So that presentation will be led by Professor Mlauzi, who is the head of clinical governance in our province. She's a clinician herself, working with other clinicians. They often experience it when the beds are getting full, or when the system is getting overwhelmed. They feel it and they see it. When the resource constraints are there about staffing and equipment, they feel it. They are in the front line. They are the soldiers in the front line of that. So their input about what the best response is very important. Rather than just us at the Command Council sitting here, she and Professor Laurel are members of the Advisory Council as well, but that's the clinical team that they are going to share with you today the sense of what is happening in our health facilities and what is being proposed, now adopted by the Provincial Executive Council yesterday. Their proposals are now our strategy. In the next few months going forward, what is it we must be doing? They will be followed. We also have a national infrastructure team seconded at my request by the Minister of Health. In June, I requested the Minister of Health that give us additional capacity, both on the infrastructure side, but also on the management, leadership, epidemiological side. So there is a team from the National Health Department that has also come into our province to look at the infrastructure. They are also going to just say something to give feedback. This is part of getting ready for the peak. But we will hear from the modeling team what is going to be the peak like, according to modeling, and how should we be preparing for it? What has changed from the initial, so that the decisions we make as the Gauteng Provincial Government are made on, they are made on scientific advice, but also on a lot of input by experts, whether it's infrastructure experts or researchers or data scientists or clinical experts. So I will conclude after they have made a presentation. I want to conclude by talking about clean governance and fighting corruption. So when they have said all the things, for us to succeed in doing all the things they will present today, that the provincial government in this next phase of the pandemic will be doing, I will conclude by talking about how do we make sure that these things happen and every cent we have is directed to save lives and doesn't end in the pockets of thieves. So I will conclude by dealing with issues of dealing with corruption and clean governance. Today, we are not taking inputs on schools. They are going to say something on modeling about what is likely to be happening also with if the schools open and what's the best way to manage that. So everything today is presented not by the MECs, not by me, but by the team of experts who come from the advisory council of the province. So I am very happy to truly welcome them today. And I would like to request Dr. Mary Kaonga, who's the chair of that panel, to come and introduce the issue on modeling, and together with Professor Bruce Melado, we will get a sense of where is the pandemic going according to modeling in Gauteng. Thank you so much. Dr. Mary Kaonga.
Good morning. Thank you, Premier, and good morning, everybody. So my task really is to introduce the first of 3 presentations that the Premier spoke about that are the anchor presentations for this media briefing. And as the Premier mentioned, the first presentation is really going to be presenting the modeling work that has been happening under the auspices of the Premier's COVID-19 Advisory Committee. So just a few words to just really contextualize this presentation. So I'm sure those who've been coming to these media briefings have seen Professor Melado before presenting where the trajectory of the epidemic is going in Gauteng. So today what we're doing is providing an update on what's the status of the epidemic at this moment, based on what we've been seeing in terms of the July data. So I'm sure, as you saw, in June we had a huge surge, an increase in number of cases. In mid-July, there were quite a high number of cases, and by the second half of July, we started seeing a reduction in the daily number of cases. And so obviously, models have to be revised, and the model that's been developed in Gauteng is being revised continuously based on what we're learning on practice. And so that's what we're going to be presenting today. And just the second word really I want to say is that I think we all know models are useful for a number of things. So one of the things that we use modeling for is to help us predict or forecast what are we expecting to see in the next few months in terms of number of cases. Where do we expect the peak to happen? And that's an important question that I think policymakers ask and the public also needs to know and often wants to know. So one of the other ways in which modeling helps us is it allows us to sort of develop certain scenarios. What if? So what if we move to level 2? What do we think was going to happen to cases and to the peak? What if we moved to level 2 but remained with a number of interventions such as schools remaining closed? What if we opened up schools and stayed in level 3? So there are a whole range of scenarios that we can develop that modeling allows us to test using these models. And I think those are important questions that this presentation is going to explore. And the third thing I want to really say is the fact that I know we've seen models. Models are available at a national level, but I think the unique thing about this presentation and the whole presentations that will be taking part in today's session is that we're actually presenting the Gauteng picture. And across this country, I'm sure you've seen the trajectory of the epidemic change is different in different provinces. And what we want to highlight today is this is the picture of Gauteng. This is where we are in terms of our epidemic at a macro level. Then following Prof. Bruce Melado's presentation, Gillian Murray from GCRO will then come and drill down and say, what are the things we need to be looking at the ward level? at the local level where we're putting in interventions, in Gauteng specifically. What are the issues? What's the science that we need to be using to inform our response? And then the third presentation from Prof. Mlaudzi, as Premier said, is then going to go to say, what are the clinical considerations we need to put in place when we're making decisions? So, for example, to what extent do we need to be strengthening our hospitals so that not only are we responding to the demand now, but also the demand that we expect to continue into the future so that we're able to respond to that even as we move to different lockdown levels. So without going too much into detail, I would like to invite Prof. Bruce Malado to give the first presentation, which is really talking about the predictions in terms of modeling, as well as what we expect to see in terms of different scenarios. Thanks, Prof. Malado.
Okay, thanks Premier, MECs, HOD, and thanks Dr. Kawonga for the excellent introduction that puts everything in context. So let's dive into it. So as Dr. Kawonga already indicated, we are giving an update on the recalibration. We call it the recalibration of the model or the readaptation of the model to the new reality and the new numbers. So let's look at the top graph there, where you can see in green is the total number of cases that you can clearly see it seems to be leveling off. And then when you look into the composition of those cases, you see that the number of recoveries is already solidly above the number of active cases that seems to be leveling off. Now, if you go to the lower picture there, we see something that has already been highlighted by many news outlets and the province and the central government, is the fact that the daily occurrence of new cases reached sort of like a maximum and then it went down. Now, it's very important to interpret these numbers correctly because that affects very seriously how we model the pandemic and how do we act as a result. So in order to understand and correctly interpret those numbers there, and let's focus on the lower graph, you basically have to be cognizant of two processes that are talking to each other. One is the random transmission that occurs everywhere in the province. That's the real driver of the pandemic. Unfortunately, the pandemic is everywhere. And then those random transmissions generate hotspots. So what we have observed in the province, after careful analysis of the data, is that that apparent increase and downturn is the result of the decline of hotspot activity, which is the result of the combined efforts of the province and different stakeholders in the province, and the strategies will be dealt with by Professor Mlaudzi, and of course the working with the population in enhancing adherence to social distancing. So what this means essentially is that these random transmissions continue, and that is depicted in the red curve, continuously, slowly progressing towards the peak of the pandemic. And what we saw is basically the fact that the surge was driven by hotspots that were put under control. This is by no means the peak of the pandemic. This is the end of the first surge. Unfortunately, the fundamentals for the second surge are there, and that's what we have to be very careful about. All right, so let's go to the question of modeling hotspots, because in order to be able to model, we have to first understand from the data, using artificial intelligence, how hotspots look like, how do they evolve, and how should we subtract them in order to see the underlying true dynamic of the pandemic. So in order to do that, we basically use artificial intelligence techniques that basically what they do without prior knowledge of what happens on the ground and what is the real dynamic that drives those hotspots, clusters different hotspots to create the final clusterization of the province. And then we look at those clusters and we analyze them to understand how they look like and what is their lifetime. So that is basically how we learn from the data in order to determine and characterize a very complex process, which is hotspots. Now, once we understand those, once we understand how they evolve in time, now, once we understand how to remove them from the data set, we basically are left with the real underlying dynamic, the real pandemic, so to say. So this is an example of how this clusterization works. This is basically a graph of a section of the province where you see different hotspots, and then if you click on one, through the graphical interface, you basically see how the number of cases evolve in time, where they start with a small number of cases, then the number of cases grows, and then it levels off. And that basically happens with the absolute majority of those hotspots. As a result of that, you basically have a slowing down of those hotspots as a result of the action of the Gauteng province and other stakeholders and the population. With that in mind, we are now ready to recalibrate them all. Now we are ready to understand where the pandemic is going. That's what we call, that's what we refer to when we say recalibration. Now the most important data set for us is July data, because July data contains a very important piece of information, which is how does the population react to non-pharmaceutical intervention? What is the level of adherence of the population to social distancing? And that's what drives, to a great extent, the pandemic. So what we observe, this plot is a bit technical, but bear with me a little bit. This graph gives you the transmission rate, the speed with which new cases appear every day. Something very large means the pandemic grows fast. Something small means the pandemic has slowed down. So once we have removed those hotspots, that now we understand by means of artificial intelligence, where we see that in July, the pandemic has strongly slowed down. That is basically an empirical observation, not a theoretical observation, but basically an observation coming from the data, which is consistent with the hypothesis that the population has significantly enhanced adherence to social distancing. So we have to take that as a baseline in order to make predictions and understand now and make predictions as to where the peak is given these slowdown we observe in the data. So now let's move on to new predictions. That's what people want to hear about. And let's spend some time on this graph here. So on the basis of certain features of the data, we have devised two scenarios. One, an optimistic scenario, another, a pessimistic scenario. An optimistic scenario is consistent with the peak being pushed further down the road, and an optimistic closer to basically now. So let's focus on this graph here. So those red and green curves that continuously grow, those are cumulative cases. Cumulative cases always grow, faster or slower, but they always grow. Now, in order to determine the peak of the pandemic, we have to focus on this blue curve at the bottom that basically curves down in the optimistic scenario around December, January of next year. Now, you should not be worried about the fact that if you look at the lower left corner, there's still a difference between the data and the model. This means the difference is hotspots. Those hotspots have been removed, and what we see is a true dynamic of the province, a true average dynamic of the province, and how it will evolve in time. So this basically means that this strong enhancement in adherence to social distancing and other measures have basically, so to say, quote-unquote, flattened the curve by pushing the peak a few months down the road. In the pessimistic scenario, you have a peak or a mild peak, which is about 20% higher in amplitude with respect to the optimistic scenario that will peak around November, December, but still is much milder than previous scenarios that we had in earlier updates. Now, the question that Dr. Kawonga raised, which is an important one in terms of
Policy making is that what if we assume a certain scenario? For instance, what you see here on this graph is that what happens if we suddenly open all schools around the end of August? So what you see in blue is the pessimistic scenario, which would have a peak around November, December, closer to December, with a maximum number of active cases of around 100, 120K in the province. Now, if in August we open the schools immediately, what happens is that the peak basically is brought forward, and the amplitude of the peak, the maximum number of cases basically doubles around 250, 270,000. This basically speaks to the fact that small changes in policy or behavior do have a very strong impact in outcomes. So everything that we do has to be done in a phased and a gradual way. Another look at a different scenario is what will happen is if, as of the end of August or beginning of September, we move suddenly from level 3 to level 2, and that the comparison is made between the orange curve, which will be level 2, moving fully to level 2 compared to staying where we are today, where you can see clearly the peak is moved by more than a month, and the amplitude, the maximum number of cases would basically surpass 400,000 cases at any given time. Now, there's, of course, a lot more happening, but we basically have distilled that for you so that we have very clear punchlines as to what actually this means in practice. Whatever we do has to happen slowly and in a phased way. All right, so let's draw some important punchlines and conclusions here. So the first thing that we have to, of course, commend is the fact that the province has been able to handle the first surge, the first significant surge, under the current levels of lockdown. That is an extremely important piece of information, not only for modeling, but also for policy making. Now, despite that success, we have to be cognizant of the fact that this maximum and this drop is not the result of the pandemic having reached a peak. Unfortunately, that is not the case. Because the possibility for new surges are still there. The fundamentals for new surges and new increases and new drops are still there because the pandemic is essentially everywhere. Transmissions happen randomly pretty much everywhere in the province. As a result of that, it is our advice that non-pharmaceutical interventions need to continue. And that being said, of course, the province, given the success of controlling the first surge and the hotspots, we are now in a position to relax the lockdown. Now, clearly there are different scenarios. The relaxation of lockdown is a complex matter, and from the mathematical standpoint, and also based on experience from other countries, it is very clear that whatever happens, whatever relaxation takes place, or whatever configuration of that relaxation takes place, that they be performed gradually and in a phased way. Overconfidence, unfortunately, many times doesn't pay off. Thank you very much.
Good morning, everybody, and thank you, Dr. Kawunga, for the introduction. My name is Gillian Marie. I'm a researcher at the Gauteng City Region Observatory, and I'm representing a team of our researchers and some of the work that we've been doing to try and understand some of the impacts of COVID, and as the Premier said, particularly focusing on trying to understand some of the community and spatial dynamics and how we're seeing this is affecting the city region. I just want to acknowledge that the work that we are doing is done in partnership with many of our colleagues within provincial governments and other organizations, and particularly to acknowledge here the research and analysis work stream, as well as the Gauteng Department of Health and the Office of the Premier that have been involved in the work that we're doing. So I'm going to give you a couple of slides talking through three key trends. But before I do that, I just want to show you a quick slide and try and contextualize some of the impacts, because a lot of what we do as an urban observatory is try to understand what some of the socioeconomic impacts are. So we did have a look at using a particular data set of night lights, and that shows what activity is like at night. And it's a really useful indicator to see what human activity and changes in economic activity are. And what we've noticed from that, we've shared two maps with you on the slides. The first on the left-hand side, showing the cooler blue colors, is that there was a lot of dimming of lights, particularly during the early stages of level 5 lockdown, showing that there has been really strong adherence to conditions, and movement was really curtailed. We have seen, as the levels of have increased and more activity has taken place, that we're seeing a lot more activity happening, but it certainly isn't at the levels that we were seeing before the lockdown. And this has a number of implications. You know, we've been experiencing the pandemic for a few months. We're starting to see and experience and hear of a lot more issues around lockdown fatigue, cases in some areas where we're starting to see complacency to preventative measures, and it's had enormous widespread impact on society, on communities, and on the economy. Many people have been experiencing high levels of stress. So what I want to do with the presentation that I'm going to share with you on the next few slides is show you both how some of this COVID data has manifested, but how it has impacted on communities and some of the aspects that we think should be taken into consideration. So first of all, I want to contextualize that with vulnerability, and who do we think is vulnerable, and why does vulnerability matter within the context of an outbreak? This was work that we did quite early on, in fact, right before lockdown level 5 happened. And I know the Premier has spoken to this extensively. I'm not going to dwell on these slides, but I do think it is worth noting that in trying to measure who's vulnerable and understand who's vulnerable, we do see quite strong spatial trends. So the slide that I've got showing you is where we've had a look at a number of indicators in an index that we compiled to show where communities would have difficulty maintaining social distances and preventative hygiene. And we looked at a range of factors included in here. So for example, household crowding, which we know from seeing infection data coming in. Crowding has certainly been something where we've seen higher levels of spread of infection. We've looked at where communities have shared sanitation and where people don't have access to electronic communication amongst a range of other factors. So here the map does show you that suburban, richer northern suburbs have a far lower risk and it's much easier for them to be able to maintain social distance. And some of the real challenges that we noted at the beginning would be particularly for communities in informal settlements, on the peripheral areas, as well as quite notably people who live in high dense settlements within our CBDs as well. We looked at a second index, and this looked at particular vulnerabilities around health and social vulnerabilities. Not quite as strong of a spatial trend that we see there. Some of our data where we ask for people with pre-existing conditions, for example, is reported consistently across the province, but we do see some trends, particularly where people have experienced difficulty accessing healthcare in the past and those who have access to medical aid. What this data has told us is that the impacts are likely to be felt unevenly, and that's what we have seen unfolding in the last few months as well, and that poorer communities are likely to bear the brunt of not only COVID itself, but also being able to manage their way through the large social and economic impacts that we've had to bear with the necessary lockdowns that we've had in place. So that's just by way of contextualizing. I want to just shift gear now and talk about a particular type of vulnerability, where we have communities that have really acute vulnerability. And in this case, what we're trying to do is start drilling down into the spatial data of where COVID infections are taking place. And here we were trying to understand where we were seeing multiple cases happening at the same site. And in many cases, overwhelmingly, what we were seeing is clusters breaking out from early June in long-term care facilities. Now, long-term care facilities are those that provide both rehabilitative as well as ongoing medical care to people who live within these facilities. Typically, it's old age homes, but it does include homes and facilities for people with mental and physical disabilities or people who are needing long-term rehabilitation. What's important to note with these, and what we're seeing in some of the infection data, is these infections typically have shared common spaces, shared dining facilities, shared bathrooms, so many similar in infections we've seen in hostels as well, that there's a particular risk to outbreak over here. So what we did here is we've mapped and tried to identify all the cases of where we're seeing outbreaks in some of these facilities. It is worth noting that to date in the data, we've noted 232 facilities that have been identified with well over 2,000 cases within these long-term care facilities. Now, it is worth noting, I just want to say that in order to be able to do this, the data we use is what comes through the data feeds of when people test positive, and we rely on address data to be able to do that. And given the complexity and the urgency with which things are happening, address data isn't always populated completely. Sometimes an address is missing, it may be partial address, and we're unable to identify exactly where that is. What that means is that this is probably an underestimation of the number of infections that we're seeing in long-term care facilities. There's a couple of areas that they have been concerned. We've noted 3 facilities where they've been well over in excess of 100 cases in those facilities, another 9 with over 50, and at least another 20 plus who've had over 20 infections within these facilities. In many cases, what we're seeing happening is 1 or 2 residents will test positive. There'll be a targeted testing that happens in that facility, and then many more cases will be reported, showing that that infection spreads in these types of facilities a lot quicker, and it's very difficult to be able to maintain what's happening in there. We are noting, and I think this links very nicely with what Bruce was showing, is that we're seeing plateauing of numbers. So the number of active cases in these facilities is a lot lower at the moment, but we need to be really careful because, again, we have this trend where we're continually seeing new sites where there are positive cases that are presenting, and that infection in these long-term care facilities is likely to spread a lot quicker than in many other environments as well. So certainly, and I think this is a lot of what Bruce was talking to as well, we may be seeing plateauing, but this certainly does not mean that we can let up. We need to be as vigilant as what we have been in the past. Okay, so just quickly on those facilities, I just want to highlight as well is that we're not just talking about the elderly within the facilities. Typically, yes, 60% of the population in many of our care facilities are the elderly, but the rest are a lot younger, people with mental and physical disabilities as well. There are enormous cases of stigma, of fear. Many of these people have been isolated from families and communities around the fear of spread. They know they are more vulnerable. They've seen many of their friends and fellow residents being sick. And the staff in these facilities as well are also under extraordinary amount of pressure at the moment, and many of them themselves are testing positive. The implications for this is it's very difficult to manage these patients. It's difficult sometimes to self-isolate because they may have conditions that make it difficult. And in many cases, sometimes these facilities have just been unprepared for the size of the issue that they have been facing, and there's a large need support, and particularly for PPE within them. One of the things we would like to understand and that we would like to pick up on is that we're unable at this point in time to point to the number of deaths in these facilities. One of the things going forward is starting to connect all the different data sets that we have around what's happening in Gauteng, and that can start telling us a lot more comprehensive picture around some of these effects on particular types of communities. And we know in these facilities that death rates are fairly high. Okay, so that's looking at cases in long-term care facilities. The issue I want to conclude with is we've seen some really interesting trends and stuff that are worth noting around age and gender and how COVID has manifest. So the slide that I've put on the screen at the moment, what we've done over here on the purple line, and I know it might not be that clear, but the purple line shows you the population per cohort, per 5-year cohort, the percentage of people in that cohort. So it shows you that we have a very youthful population in Gauteng. We have a large number of people in their early 20s and 30s and younger. And then it tapers off to a much smaller portion of the population is elderly. On the red curve, which we've put over there, is the percentage of those cohorts which have tested positive for COVID. So we're trying to see how, whether there's correlation between the amount of people in the age group and who's testing positive. Similar to what we've seen internationally, the bulk in many of our youth, you can see that the percentage infected for younger age groups is much lower than the percentage of population that we have in there. There's been very little change in that trend over time, although we did note a very slight change as school went back. Just because that change is small, though, again, linking back to Bruce's presentation, doesn't mean that the impact of schools and the youth that are infected doesn't have a bigger effect. The main trend, Anya, which is quite interesting, is that the bulk of the infections that we're seeing are of people of working age, so between the ages of 20 to 25 to about 55. Certainly a lot more people within that age group are testing positive. We also see a slight uptick in the elderly, and that's probably related to the fact that we are seeing higher numbers of infections in care homes, as well as closer monitoring of people who are older. What we then did do is take that age data and have a look at it for gender. So the graph that we're showing you is the infection data from March up until date, and we're showing that curve that Bruce showed in his, Prof. Malata showed in his previous presentation as well. So showing that exponential growth that we saw over June and July. What is interesting when we break that down is starting from around about mid-June, there's been an increasing gap in the number of females versus males testing positive. And overwhelmingly, we've seen an increase in the number of females testing positive for COVID. At the moment, it's about 56% females testing positive. Around 51% of our population overall is female, and that number has stayed relatively consistent for the last few weeks, typically between 55 and 57%. So approximately 23,000 more females are testing positive at this point. We did look at this internationally to see, is this something different that we're seeing here? And there is a little bit of a difference in the trend. Internationally, against UN data, we see that females tend to, more women to men test positive in developed countries versus more males in developing countries. So it is a slightly different trend that we're having a look. We took that data, and I'm going to take it back to that initial graph that I showed you around the population, showing that split. And here we've highlighted again the same orange color showing females, the blue color showing males, showing you that disproportional, very large number of females, particularly of working ages, that have been testing positive. Now, there could be many reasons for this. We know women are more likely to seek medical care when they are sick. We are not quite sure how that relates to testing numbers as of yet. One of the key reasons we think this is happening is that particularly from level 3, when going back to work, women are more likely to be in vulnerable higher contact care positions. So women are our nurses, they're our cashiers, and they're more likely to be at the front line and at risk of infection. It may just be that more women are presenting for testing as well, as I said, because they are more likely to present for testing when they get ill. We know there is very targeted testing at the moment for pre and post natal care for women going into hospital. And we also know women are far more likely to have to stand in queues to, for example, collect child support grants. So some of the implications we're saying, and we'd like to point out over here, is that we would like to be able to see some of the gender splits, so to understand if this is a general trend, if it is a case that more women are presenting for testing. And we're also recommending that in the interventions that we have, is that we do start having a look at particularly targeting and supporting women of working age. A final point I want to note over here, and just to try and look at it, to try and disaggregate it spatially as well, is this trend isn't universal across the whole of Gauteng. We are seeing differences in different suburbs. For example, in Carltonville, where we know there's a strong mining population, in that area there's a far larger proportion of males than females who have tested positive. So there are differences which we do think, and that's very important because it comes back to that vulnerability work that we were talking about. And that's the point that I'm going to wrap up my presentation on, oops, I've just gone too far over there, is that if I take what I started with about the vulnerability work, and here I've split it up for women. Again, these points that I have made, women are more likely to live in crowded conditions, they're more likely to have to use public transport, they're more likely to be in contact work, they're less likely to be able to have access to medical aid, they're more likely to be able to have difficulty accessing money. And when we start having a look with that against some of the spatial trends around their vulnerabilities and where particular challenges are, that starts, I think, helping province itself. And what we're recommending is to tailor specific responses to specific areas and understanding, again, as Bruce said, how some of those hotspots have manifested and what some of the conditions are within there, and being able to have a look specifically and targeted at that. So at that point, I think I'm going to conclude my presentation. I've just given you a quick stop on that. I've just finished it over there. We've made as much of this data possible available to governments, to municipalities, and to the broader public as well, that people will be able to access and engage with that work as well. Thank you very much.
Good morning, everybody, and good morning to the Premier and the rest of the principals and this side of the seats, and all the people who are listening at this point in time. My name is Mperekezeni Mulaudzi, Professor of Pediatrics and Child Health, and I'm representing the Gauteng Clinical Governance Advisory Subcommittee, which is a subcommittee of the MEC of Health in Gauteng. And following on the presentations that have been made so far from our colleagues on the modeling and the spatial work and what is happening on different communities, I would be bringing the aspect of the clinical care, and having been experiencing the work and the effect of COVID on the ground with the clinical work that is going on, and also with the new modeling that is on, what should we be thinking of doing going forward? So it is really a presentation of set of strategic goals that we are saying going forward, each one of us, whether we are in the community or we are in the hospital, or we are in the malls, in the shops, or we are in any of our different workplaces, we should be working towards some of those strategic goals to be able to really defeat this COVID, or even reduce the number of people who will be affected or killed through the COVID-19. So there are three strategic goals that we have put forth, which one is to reduce the transmission. The second goal is how do we care for those who have COVID positive. And the third goal is how do we deal with the patients whom we know that we now cannot manage, and they will succumb to the disease of COVID. So I would start by talking about the reduction of transmission. Of course, there are different ways, strategies that are there, but for us, what we want to put across is that we put them in two different ways. The reduction that should happen in the community, and also we shouldn't forget the reduction of transmission and preventing it from happening within our healthcare facilities and the clinics. And in this, what we are saying with the reduction, there is an important aspect that we would want to strengthen and work with the ward-based primary re-engineering to actually achieve this goal. So the primary healthcare approach is very important, because as far as reduction is concerned, it is the behavior of us as a community, wherever we are, that prevent that continual transmission of the COVID. And that with that reduction, one of the important aspects of that is to identify the patients or the cases that become positive, and also those who are in close contact with the patients who are positive. By doing that, then we have to also kick in the method of tracing and also monitoring those who are contacts and with patients who are COVID. Because the important aspect is that we need to reduce the possibility of a further transmission from one positive case to another positive case. And we can't do that if our primary healthcare facilities are not geared and strengthened to manage the patients we call PUI. That's the patient under investigation. This is a patient who goes to the primary healthcare as a first level of care with the complaints or symptoms that might suggest that they have COVID. So that area and the first level of care should be able to manage those patients and then redirect them to specific places. And of course, therefore, once we identify the patients who are positive, we need to deal with that aspect. But we also need to deal with those who are in contact and have to say, are they patients who would have to go for the next level of care where they need a hospital admissions, or are they patients who need to stay, who can be at home? And as a result, is their home surrounding sufficient enough for them to be able to do the social distancing and the quarantining that we are asking to be able to reduce further transmission? And therefore, the use and the availability of the isolation and quarantine facility is important in this strategic goal of reducing transmission. And then when we come to our hospitals, clinics, and health facilities, and I think one of the important things that needs to happen, we need to strengthen our OHS services so that they can be able to support the healthcare workers within the facilities to prevent even further spreading. And in this case, spreading can happen between a healthcare worker to a healthcare worker, can also happen between a healthcare worker and a patient, and can also happen between a patient and the patient who comes to the healthcare workers. And those are important aspects which, beside the OHS, the use and the availability of the personal protective equipment, which we call PPEs, is very important. And also our measures that we have been having also as a health facility of infection prevention control. The protective gear is very important in that aspect, and it doesn't only work for the issue of reducing transmission, but it also works to make sure that we still have adequate healthcare workers to continue to provide services that are needed by our people in the province. And I want to clarify that when I'm talking about a healthcare worker, I'm not talking about a doctor only. I'm talking about the doctors, I'm talking about the nurses, I'm talking about the cleaners, I'm talking about the porters, those who are providing those services and support services within the health facility so that the health service is delivered. And just to expand on the primary healthcare reengineering, ward-based strategy is that we are talking of a concept of a health catchment area, for which in that health catchment area is looking at the wards and municipality wards and the sub-wards where they converge into a healthcare facility, and how we work together within that sphere to actually be able to work towards the goal of reducing transmission. And in that sphere, we would be expecting that there would be the primary healthcare clinic, the ward-based outreach team, the community healthcare workers, the private GPs, the other public health streams, which involves the tracking and tracing, and other non-governmental organizations that are always so paramount in social mobilization of our communities and communication in understanding how we protect our communities and reduce further transmission. And in that health catchment area, there are important things where it's not only about day-to-day work of reduction, but also response to when there is hotspots in that aspect. With a corporate governance, which is of the chief director, but a clinical governance, which is of the family physician, and also for the public healthcare specialist when it comes to the hotspot issues. I would go to the next strategic goal, which is care and reducing death. So this is really about how do we look after patients that have now been diagnosed and have come back with a COVID test that is positive. It is important, of course, to understand that not everybody who is COVID positive will be presenting the same way. And there will be those who would not have symptoms. There would be those who would have mild symptoms. There would be those who might have a severe disease, and there will be those who might even have a critical in critical position where they may also need critical care. So it's important for us within our facility to risk strategize them into those categories so that in the end, those with a mild, who are described as mild, can actually be going back to the community, to their homes, or they may use the hospital, the isolation facilities that are there. And once we diagnose that patient, tracking and tracing should kick in, and we'll be able to trace all that. And then once we have identified that patient, those that we have said they can go home or they can go for isolation facilities, they need to be monitored because we know that for some, they may have a period where things will go well and they will recover without any consequences. But we also know that there are for some who would start well, and within the next week after that, they may start getting sick and even sick to a point that they may also need critical services. And that is the value of and the importance of monitoring so that we can be able to pick up earlier before they are severely ill and be able to intervene. And that is where that health catchment area and the responsibilities there are quite important. And we have so-called this a honeymoon period, that you're well, and then after that, you then get severely ill. And this monitoring requires an oversight of our community health care workers with an experienced physician, where in this part, really our private GPs can come in that aspect to really support the primary health care nurses and the community health care workers. And with that, an important, robust up referral and down referrals system is important. Once the patient gets to the hospital, of course, we need to have adequate services and medication and human resource and technology to manage this patient. So it is not enough to just say, I have a bed, and then there is no important equipment that is needed to monitor that patient, or there is not important human resource to manage that patient. It might actually not even be, it might be that in that day, the doctor and the nurse did pitch up at work, but there is no cleaner on that day. And one of the important aspects of the infection control measure and reducing this strategy, it has to do with having clean environment. And it's important that those aspects are really jacked up in our system to provide that services. We are already an under-resourced service and country where we know that the human resource is not enough. But the disease doesn't make it easier either, because the very same healthcare workers are also getting affected, reducing the limited resources that is already there. And together with that, we need a strong emergency transport services between referral areas. I want to talk about the last one, which we struggled. What should we call it? Is it a decent death? Is it a good death? Is it an end-of-life care? But what I want to bring forth is that this current disease of COVID, we do not have the treatment for it. We have supportive measures to deal with whatever presentation the patient has, and we are aware that there are people who will succumb to this death. So we need to start talking about this subject. As difficult as it is, we need to start talking about it, because we need to prepare such that even though we can reach a stage as a clinicians to say that whatever we are doing further, it's really a futility of care. It means it won't bring any change. It is prolonging the suffering of the patient. In some cases, it might be coming to say, to you as the community, to say that we have at this point in time, we understand you have many other conditions with this COVID, and we know that even if we go further, the prognosis or the chances of you living may not be because of the other comorbid existing conditions that have been. And so it is important that as a community, within our homes, within our spaces, and the close people with us, start talking about our wishes. What is the wish? Should I be reaching that stage? That the clinicians, as they look after me, these are my wishes on what is what should happen on my end-of-life care. And together with that, it means the palliative care is an important aspect. The issue of palliative care is not new. We've been doing palliative care for patients with cancers. We've been doing palliative care for patients for HIV long before we got to have treatment. So it is not a new, but it is a treatment that we need to also strengthen so that we can also be able to have a dignity towards the end of life. And so family engagement earlier on is is an important aspect. So I just want to end my presentation. I think this went as in a wrong place, but this is to say within those 3 strategic goals, there are many other activities that have already been put forth on how each and every department within the province should be finding a place on how they can do some work in either preventing or reducing the transmission, or in the care of those who are infected, or even in the last part when we deal with issues of end of life or even burial. And I won't spend time there, but just to show you, if you look at this slide, I don't know if I can point, you can see on the sides where there are different areas and activities that are happening and how they align to the strategic goals that we have put, and have put each and different numbers to be able to say they fit in. So even if you're a Department of Social Development, there's somewhere that you would fit there. Or a Department of Infrastructure, there's somewhere that you would fit there beyond the Department of Health. So my few last third will be talking about, yes, we have the 3 strategic goals, which we have actually consolidated the 6 work streams within the strategy of the department and the World Health Organization streams on how we deal with COVID. There are really overarching issues that are important for coordination. And this is the issues of clinical guidance, particularly the guidance on how we manage the patients, and also about the public health strategies, how we inform the decision. We also need to have a better, a more strong communication strategy, which is not only to the healthcare personnel, but also to our communities. And that's where that health catchment area is very important, with social mobilization and communication, so that our communities understand what is this disease, what should we be doing about preventing, and what should I do if someone is ill in these cases. And also really strengthening the messages that we are already giving in the community and how they can chip in. And we really, an important overarching that you've also learned now from the team that have presented earlier, from the modeling and the spatial issues, is that we need data so that we can be able to provide evidence-based decision-making. So our health information system and our ICT within all our facilities and our structure need to also be prepared to do this function. And the genuine intersectoral collaboration is important. I've already been saying different departments that may also be important in that aspect, and non-governmental organizations that have been providing a number of health services and support even before the advent of COVID. We need to strengthen our district health system to make sure that we deal with the issue of sustainability and be able to continue providing a good quality health services for the population of Gauteng, even beyond whether the pandemic will be gone for COVID. And that's still yet to be seen. We do not know. It is a very new disease. And even up to now, it's not yet a year that we have had a disease. We are learning with recalibration of modeling as we see how the disease is behaving. So there is still a lot to learn from it. But at the same time, we still have to continue to provide the services. And as a result, the importance of coordination of human resource, occupational health services, and the infrastructure is very important, so that we are able to plan, as the modeling tell us that these are the beds that we need. And as the finance people will be saying, this is the money we have, we should not find ourselves creating a physical bed that will not have a human resource or even the equipment and the technology to finally deliver the health service that bed it was purposed for. And so we want to say that we need to strengthen the existing facilities and prioritize them in this aspect. And also, in this way, we would also be doing things differently. We know we have norms and standards that says this is what should happen at the CHC. This is what should happen in the district hospital. This is what should be happening at a regional or provincial hospital, tertiary or central hospital. There will be changes on that norm so that we can be able to reduce the death in these cases. And certain things that would not usually have been in the, as a mandate of what should happen at the CHC or a district will have to change for us to curb this disease. The other overarching issues of sustainability is really important, the personal protective equipment. Although much has been done, more still need to be done. And despite all the things that we hear, I want to also raise another aspect of the personal protective equipment, which is quite important, that you may have on the ground an equipment that has been certified by SAPRA or CSIR that it will do the function that it will do. But when you have wear that protective equipment, especially with the mask, it doesn't fit the face because they have been designed for a different population. So in a way, what does happen is that we have equipment that is certified, but it is not doing its full capacity work of protecting that healthcare worker. And these are issues that SAPRA and CSIR in their testing will have to bring it in. The second other aspect of the PPE that is quite important is that the sizes. We actually have a population that is quite obese. And I know people can attest to that. If you go to one shop, for me as a lady to buy a shirt, in this one shop, I can buy it for this size, and in another shop, I can buy it for another size. And so it is important for us to also address those aspects when we are making and producing and certifying the PPEs that are to be used on the ground. Oops. I want to end by saying, I want to, as a team of the Clinical Governance Committee, and this is also together with the public health specialist, to urge that and to go forward that we would be prioritizing really our current health facilities so that we can strengthen the health services even beyond COVID and for other patients who may present without COVID. And there are two important ways that are there that has been already addressed, that the facilities have already started repurposing the beds, and we need to go back to say how much of that and how many numbers of bed can we repurpose, and how much from the structures that we have, we can have additional space for beds. But in that case, the same concept again of functional beds I have talked needs to apply. And we need to create some new beds in the current facilities so that going forward, we can also provide better services. And there is a need to re-look at the temporary structures that have been fronted initially as the way in which we should deal with the disease. I, for one, from the beginning, do not necessarily say that was a wrong decision to consider field hospitals, but we are learning things differently as we go on to say that going forward, is it still the method that we should continue to use? And so we are recommending that wherever there was a consideration of a field hospital, it should be re-looked. Do we need a field hospital, or should we redistribute those beds that were going to be in that field hospital to the current facilities that are there, with the spaces that they may have? That's one. And secondly, to also look at the communities that already we know in our plan we would have preferred that there is a district hospital there, or we would have preferred that is a CHC there. That should we be putting a new structure, then a new structure should be in those places, because then continually we will not have a wild, an elephant that is built and we now have to get people to repurpose to use it, but now we would actually have a service for the communities that we did not have before. And lastly, the other temporal structure there would be the tents. And to say that the tents would be really are not suitable for the use of inpatient care. They can be used to supplement where the emergency department sections for screening may not have adequate space to have the different separations of patients whom we are calling PUI, COVID post-patient, and other type of patients. And lastly, I want to end that this disease, we do not have a vaccine. So we don't have a way to say, I will give you something to prevent you from actually getting it. And learning from research is that sometimes we start with a hope that something will be there soon, and it is not soon. I remember in my earlier days of HIV, and one president coming and saying, the vaccine will be here within a year. We would have a vaccine. Even up to today, we do not have a vaccine for HIV. So I want to bring this to us as a population of Gauteng. The way and the current situation it is, the way to prevent the spread of this disease is how we behave. We do not have anything else. And I'm pleading to everybody else to say that let us not end up believing that the behavioral method works when we see people dying, but to start saying, with the modeling that we have seen so far, and with the changes that have been pronounced by the province earlier on how we made some measures within the level 3 to deal with this non-pharmacological intervention, we are not having the peak that we have expected that we should. So I'm saying those measures work. They may not be the only reason why things we're not getting the peak as we have expected, but it is an important reason for us to consider. So I want to end by saying, wash your hands and sanitize. Wear your mask. And you wear your mask so that should you find yourself in an earlier process where you have a disease and you have not yet been diagnosed, you would also be able to protect another person who's next to you. And that is called solidarity, not thinking about me alone, but also thinking about my counterpart people. I want to talk about the social distancing, which is also another aspect that is quite important, because that prevents the transmission between the two. And want to leave you with a question, or with some things to consider. It is difficult to do. It is a change of behavior that we are not used to. But it is to say to us, what is the reason why we are doing this, and why should we do that? And that is to protect yourself and to protect the others. And also to say to ourselves, there is something that we can do to prevent this disease. But also to say, these measures that we are talking about, especially the one of washing hands, they are not new. So I want to leave you with the questions. You think that these measures are only for COVID, but these measures are for multiple diseases that we suffer. How many of you who have been struggling now and again from somewhere else with diarrhea, you do not have diarrhea? I want to leave you with another question. Have you experienced the flu season, the flu among each other, like you have experienced before? It's winter. We know so many other people. You would have any other second, third person would have flu and will have symptoms, as we know. But is that what you are experiencing? So you might think that this is only for COVID, but it covers also other diseases that for now, we on the ground, we can also tell that in our hospitals, we have not experienced the flu number of patients and complications as we have expected, and we know how it is in the previous years. I work with the children. I have seen less number of children coming with diarrhea. But it might be a different exposure for somebody else, where maybe water and sanitation and all that is not happening. So I want to say, though these measures have gained momentum with the COVID, there must be our lifestyle changes. Thank you.
Good morning, everyone. I'm Christy Engelbrecht from the National Department of Health, Health Facilities and Infrastructure Management. I'm going to provide a brief background with regard to our involvement here in the Gauteng province on the COVID-19 pandemic, on the infrastructure, specific to the infrastructure environment. Now, with the outbreak of the COVID-19 pandemic, the National Department of Health took the lead to develop guidelines. Specifically, what we were focusing on guidelines was on the quarantine facilities, isolation facilities, surge capacity, fever tents, field hospitals, 30-bed prefabricated wards and alternative building technologies that can specifically be applied to the COVID-19 pandemic and the infrastructure part of it. Now, as the Premier was previously mentioning this morning, on the request from the Premier, the Honourable Minister of Health asked the National Department of Health Infrastructure to assist Gauteng Province with infrastructure implementation, specifically on COVID-19. Now, from the National Department of Health, we've appointed a Rapid Intervention Implementation Management Professional Service Provider to assist us with this COVID-19 pandemic. Now, the professional service provider that we've appointed was Secure Health Solutions to assist us with the provinces and to work with them around the COVID-19 pandemic. Now, the scope of work or the mandate for the professional service provider was specifically on the assistance with the assessment and planning of the upgrade and installation of the COVID-19 surge capacity. Now, this Rapid Implementation Management Professional Service Provider, we've got a very competent team that consists of health planners, clinical planners, quantity surveyors, mechanical engineers, electrical engineers, IT specialists, architects, civil and structural engineers. Now, the specific mandate, and I want to emphasize the specific mandate that we, on the deliverables that we are doing, and we're following an integrated approach with the provinces. We are not doing work in isolation, but we are working very closely with the provincial team on this COVID-19 pandemic. And that is the importance here. We are not replacing anyone. We are there as integrated. We are on the same level. We provided that additional assistance to the team of the province, Gauteng province in this case. Now, on the deliverables, we are providing the implementation capacity in order to create and implement the surge capacity and additional bed capacity. And we're doing it by means of emergency repairs, upgrades, new installations, conversions of existing spaces in hospitals, as well as additional capacity through temporary emergency structures. And very importantly, we're also assisting with the identification and assessment of sites in the priority hotspot areas, and to assist with the planning and layout and utilization of those sites. We are focusing on the assessment and planning that will include the assessment from a clinical perspective, but also from an architectural, electrical, mechanical engineering, health technology, as well as other engineering services that we are focusing on. With Gauteng, we provide specific assistance with the assessment, planning, design, and implementation in respect of ICU space in hospitals, high care space, as well as surge capacity in the existing hospitals. I just provided future image. And to treat ICU and high care COVID incidents with normal eye care and intensive care patients. What we are focusing on additional bed provisions, specifically on clinical findings, as well as clinical recommendations, where we are taking a look at the option between a reconfiguration of beds versus additional beds in the hospitals. We are also focusing on mechanical recommendations and with specific on mechanical recommendations. We are focusing on the oxygen installation, medical installation, as well as vacuum installation in the hotspot priority hospitals. On the electrical recommendations, we're focusing on UPS, the current condition of the UPS, transformers, as well as generators in these hospitals. And as I'm saying, we've done it with an integrated approach. We are working very closely with Gauteng DID, as well as with Provincial Department of Health, as well as members from the Premier's office, that we consist of a technical team that we are working on. So very brief in summer, as a summary, we currently studying the peak of, or the trend of the COVID-19 pandemic, and very of importance for us as health infrastructure, we want to leave a legacy behind after COVID-19, and that is of importance for us. Also, we've done the assessment, and we are busy with executing the oxygen and medical air, as well as the electrical capacity in our hotspot priority hospitals. We've done we're focusing on the 28 priority hotspot hospitals. We've already done an assessment. We are busy with the execution on the current detailed assessment that we've done. We are doing now the assessment around that. We are also assessing fever clinics, or what we call tents here, that we want to see what is we want to do the reutilization or the utilization of these tents that can provide the benefit, the biggest benefit to the province. And we also looking at alternative scenarios of identifying capacity for additional bed spaces in hospital, on the hospital sites as well. We also, lastly, we take a look at identify field hospital opportunities, as well as assessing field hospital proposals that we are currently focusing on. That's very brief from my side. I've just provided you with a very broad overview with regard to what the health infrastructure's involvement with the Gauteng province. Thank you.
So Dr. Mary Kaunga is going to conclude, because all these technical people essentially are under her from the advisory committee. She's going to conclude on what our story is going forward, after which I will come back and deal with the issues of clean governance and fighting corruption. Dr. Mary Kaunga, your concluding remarks from all these presentations.
Thank you very much, Premier, and thanks to all the colleagues who've made these wonderful presentations. I just want to the two key messages I thought I would pull out from the talks that have been given so far. So the first one, I guess, is there is good news. The second one is, however, we still need to be vigilant. So I'll start with the first one, which is there is good news. It's always good to start with a good news story. You heard from Prof. Melado's talk and from Gillian's talk that we're seeing a reduction in cases. And there's no doubt about that. And I think depending on the scenario that we adopt, the epidemic curve will be flatter and it will be wider than we had previously projected. So that's good news. And the model that Prof. Melado presented has factored in homegrown data. It's also factored in non-pharmaceutical interventions. And it's showing us that the peak has moved 2 months further back, and it's probably going to occur later than we had anticipated previously, which is around November. So again, the good news. So the other big piece of good news is that I think based on what Bruce said, and I think some of the data that Gillian presented gives us some indication that there's probably been increased adherence to social distancing and non-pharmaceutical interventions. And that's probably why we're seeing the picture, as well as all the other interventions that are happening. But, as I mentioned earlier, the epidemic is still progressing. It's not yet under control. It's just at a level where I think our health system is not as overwhelmed as was previously anticipated. So we're not experiencing the overwhelming admissions. We did that a few weeks ago, but we're seeing it's easing up now. So the bottom line, however, is that from the data is that we should expect another surge in numbers. Hence the vigilance. So what does vigilance mean in the context of Gauteng province and what we have heard today? So obviously it can mean various things, but I'm going to talk about 4 things. But the overarching message I thought was vigilance means essentially it's about not letting our guard down and being led by science to do the things that are required to keep the epidemic in check. And so there are 4 things I want to talk about. The first thing the modeling showed us is that moving to a lower risk-adjusted level should be gradual and cautious. For example, opening all schools at once while moving to level 2 at the same time may not be wise. We really need to be led by science, and a gradual approach is actually what aligns to the WHO recommendations about adjusting our public health and social measures. The WHO recommends adjusting slowly and gradually and using data to guide us on when it's time to move on to the next level and when it's time to ease up on another non-pharmaceutical intervention. And I think the modeling work that Prof. Melado is doing with the advisory committee and the work that GCRO is doing will give us guidance about some of that, and I think it's important for us to use that. So the second thing I want to say about vigilance is the importance of reinforcing the continued adherence to non-pharmaceutical interventions, particularly at an individual level. And that came very forcefully by Prof. Mlaudzi in her talk, the plea that she's making to the population about please, please. Even though there might be decisions made about moving to another risk-adjusted level, it doesn't mean we should stop using masks. It doesn't mean we should stop social distancing and individual physical distancing. And the thing that's important to reinforce that is to continue with our behavior change messaging, our community mobilization, and that's really essential to support that. So that's about reinforcing continued NPIs. So the third thing about vigilance, so vigilance also means using the science to continuously track who are the people who are most vulnerable so that we can intervene appropriately to protect the vulnerable people. And the talk by Gillian gave us some of that. And Gillian, in her talk, highlighted to us some of the vulnerable populations, the people who are most getting COVID-19 in our population. And the importance about using that science is that it guides us. It will help us to target where we should apply our public health and social interventions at community level to protect the vulnerable. And the vulnerable varies from country to country, and I'm sure from province to province. So what we have is homegrown Gauteng data, at least giving us some indication of some of those vulnerable people. It includes women, it includes people living in high-density areas, informal areas that have a high vulnerability index, so they're least likely to social distance. So this is where we need to be targeting our interventions based on what we're seeing from the science. And protecting women might require health and social development and other sectors working together, economic as well, working together to protect women. So I think what it's also highlighting is the fact that we need to start doing intersectoral collaboration, and this is what Prof. Mlaudzi spoke about in her talk. And the third area of vulnerability is long-term care facilities, particularly elderly people, though, as Gillian said, it's not only elderly people in these areas, but a vast number of them are. And I think a lot of the science we know from other countries is that one of the important non-pharmaceutical interventions, it is an NPI, is about protecting the vulnerable elderly people and people with comorbidities. And so there's some evidence from elsewhere showing if you can do that, as well as social distancing, so you can actually achieve a lot in terms of reducing mortality and infection. The last thing, the fourth point about vigilance. Vigilance is also about not continuing with business as usual or being complacent. But it's also about reviewing where we are and continuing to strengthen our public health and health system capacity, even as we know that the capacity is not being stretched at the moment. We need to ensure that we will be ready when the surge comes, because the modeling is telling us another surge is going to come. So it's about that as well. And so I just want to highlight, Prof. Mlaudzi gave a very good talk about that, so I'm not going to repeat what she said, but obviously she highlighted 3 areas, and it's about strengthening our capacity to reduce transmissions, and she talked about what that is. It's also about strengthening our capacity to provide care in order to reduce deaths. And this includes providing beds, as well as healthcare workers, protecting the healthcare workers against acquiring COVID-19. It also includes rethinking infrastructure plans and perhaps redistributing our resources in a way that more appropriately aligns to the clinical demands now, as well as the ones that we expect to happen now that we have a recalibrated model. So it's about also trying to work under the principle of developing the health system with the post-COVID period in mind. And that's the point that she was making about trying to strengthen our existing health facilities. And the third part, obviously, under that, Prof. Mlaudzi's talk, was being able to manage deaths in an efficient and humane way. So I think those were the main key messages I took, Premier. Thank you.
So thank you very much to our team of experts for that comprehensive information to share with the people of our province, the science behind everything we are doing, and also the need for us to shift when we move into the next phase. I just want to, as I conclude, just draw to your attention some of the big storylines on our data today, in addition to what you have already have. We want to say that Gauteng remains the epicenter. We want to say that. Although the surge has slowed down, the storm has slowed down, but we still regard ourselves, just by number of cases, confirmed cases, we still have the largest. The only difference is that someone is tampering with the screen there. So the only difference is that over the last few days, in terms of daily cases KZN has got more daily cases than us. But we still regard ourselves, we want to conduct ourselves and behave as the epicenter and do everything because of the size of population here, the densities, and all the special issues that Gillian dealt with. We still want to make sure that we conduct ourselves. Don't want to say that the epicenter is somewhere else. We want to conduct ourselves as such. So part of that, the news storyline is that we have, I want that slide that shows 78% of recoveries. The recoveries, no, this, back, no way. No, the provincial recoveries. This is the one I'm looking for. It is very important to understand the clinical issues raised by Prof Mlauzi. We always interested in how many people who have been infected are recovering, of course, versus those who have succumbed to COVID. But when we have more recoveries, it's a good thing for us. Those recoveries include healthcare workers. There was a period when I was COVID positive, interacting with healthcare workers in my area where I lived, where they were also reporting that half of the healthcare workers are not at work because they themselves are COVID positive. So recoveries are good for the population. So 78% recoveries this week is good for the population, but it's also good for our healthcare workers. It means there are more healthcare workers who are back at work. I always use the example of my area and region A in Johannesburg. I always use that example when I interact with the nurses and the doctors there to find out from them. So how many are you now? And they say, no, a lot of our colleagues who at some point in June who could not work and we were overburdened, a lot of those colleagues are now back. We are able to cope. So the story of recoveries is very important, but tribute goes to our healthcare workers because these recoveries happen out of the hard work of the healthcare workers. Fewer active cases. The decline in active cases is always important. I have had complaints from people who are watching this at home. They say, but when you speak, Premier, about these graphs, we don't see them. But I want to say that that green graph of recoveries, when it goes up, it's very, very important for us. And then the active cases, when the graph of active cases, that red graph goes down, it's also very important for us. So as we speak now, in the national figures, you will see we have fewer active cases than KwaZulu-Natal as a result of the daily increases. And I listened to the Premier yesterday saying to the people of KwaZulu-Natal, the storm is here. This is the message you remember we have in June, July, we were saying the same thing. People mustn't take this for granted. So there's positive news that the clinicians are talking about, that the modeling team is talking about. We've got to say, where are they happening? There's also observance that more people are responding to non-pharmaceutical measures. You remember we always complained people don't comply. Those things around parties and marches and funerals, we've got more compliance. This is tribute to the people of Gauteng. We can only make this progress if the people take this defense of themselves and their immediate family members into their own hands by wearing masks, by avoiding doing all the things. So we have fewer active cases, but we still have the largest number of confirmed cases. You will see that in the last few days we have also been recording. We have also been recording the daily number of cases has been going down quite significantly in the last few days. That's a good story. But we are not out of the woods. This is a message I truly want to send out. The storm has not passed, it has just slowed down. And it may be protracted in a sense that the modeling team now says confirmed. Instead of just thinking September, we are going to have to keep fighting much longer because it's slower, the curve is more elongated, going over a longer period of time, which basically means we need to be more resilient. We must hold on. We must continue to do these things we were doing. And from Prof. Mlauzi saying that, in fact, they have more positive effects. They have more positive effects also on just general health and well-being. Social distancing and wearing a mask, washing hands, sanitizing helps us beyond COVID. So we don't want, so as we go through this period, we want to re-emphasize to the people of our province, let's maintain vigilance, and we want to increase the level of community mobilization and community activity between the health workers, the health teams in catchment areas in the ward, and the rest. I want to emphasize those because to get to where we are has taken a lot of battle, a lot of sacrifices, including some of our soldiers in this particular case, our healthcare workers who have succumbed, but also our police, generally some of our government officials who have succumbed to this. But we must continue to be vigilant. I want to emphasize that whatever will happen with regard to the gradual, say whatever decisions are taken by the National Command Council or the National Cabinet about what the next move is, are we going to move to the next level? Whatever decisions are made here in Gauteng, we must say we are still a highly vulnerable province, high densities of people. A lot of people live side by side together. The transport mode brings lots of people together. So we are still extreme. The vulnerability and risk profile of our province is very high. Even when the numbers are slower, we must be more cautious because we don't want the second wave that's more brutal. And this important question that there may be another wave like what we went through in June, July, and it may even be more brutal. We don't want to go through that because the other important news is that on the 23rd of July, we had 7,000 hospital admissions. And that is in that period. So where are we now? I want to show you what the hospital admissions now are, just around 4,000. 4,091. So so when the system was really getting hard hit, and I was looking at the slide we presented here publicly of the 23rd of July, we had 7,000 people who were the hospital admissions has fallen. They are falling. This is also the feedback from clinicians. Hospital admissions are falling, but we still have 4,000 people who are admitted in hospital. You can see we still have 315 who are on ventilation. Others are on oxygen and room air across the system. And one of the important things about infrastructure investments is that this infrastructure, whatever we do, we must always make provision for oxygen because the clinical feedback is also that helps a lot. Not only ventilators, but just the availability of oxygen in the infrastructure we put up has been able to save a lot of lives. So this helps high flow oxygen. This helps a lot. We have learned lessons. So as we go back and repurpose and continue to redesign our various facilities, we are learning lessons on that. So the hospital admissions are an important indicator of how the system itself is coping. But again, we are not out of the woods. Emphasizing that the peak is still ahead of us. The nature of the peak may change. It may be flatter, but more elongated. And if the modeling says it may be flatter and not more elongated, it means the implications for the clinical implications is that we wouldn't have our facilities overpopulated. It means our healthcare system will cope, but we must also enhance more, as we do that, more human resources, even for that, and more medical equipment, even for that. So our resources need to be directed to where it matters most. You listened to this. It came from both the infrastructure team, but also from the clinical team, that we need to review how many field hospitals we have been planning, and ensure that this came across very clearly, and ensure that more resources is directed into repurposing the various areas of our current facilities. This is the position. You remember at the beginning we have always had this, but there was a period where the pressure on more field hospitals was building. Our advisory team says to us, continue to look at this issue of, and that includes the infrastructure team. What more beds can we bring? And they call them functional beds, not just a bed, but there will also be staffing for that and additional equipment so that there is a real legacy. So our executive council listened to all these presentations yesterday, and when we go to a meeting with the National Command Council, the meeting that we will have with the president, we are going to also be able to share with them this. So the number of field hospitals that we were planning, based on science, based on data, based on feedback from the clinicians, that number will be reviewed. That's what our executive council said yesterday. The number will be reviewed, and then more work will be directed towards improving the existing facilities. So, and that's what brings me to the important issue that our resources need to be directed to saving lives, enhancing the capacity of our public healthcare system to respond to COVID now, but not only to COVID now, post-COVID, to have a better, more improved healthcare system. And it is for that reason that, so every week I will be briefing you, saying to you that we need to enhance issues around transparency and accountability. So the first thing I would like to say is that just based on the devastating impact of the corruption related to PPE, which I've said publicly, it has eroded confidence, public confidence in the provincial government that I lead. Based on that, we have done a number of things. So last week we reported we are acting in health, but we are now also just doing all COVID-19 procurement, not just PPE. All COVID-19 procurement is also under the SIU investigation. So this is the message I'm sending out today. Not just PPE, infrastructure-related COVID procurement. Anything we have procured related to COVID, and that would include also the program we had around food relief. All that is under full investigation as well. Because we don't want a situation where today it is PPE and tomorrow is something else and the other day is another. So a comprehensive approach to dealing with corruption is to ensure that all all procurement done to address COVID-related issues must be under full watch. We must do that and act as the reports are coming. We will be taking action as the SIU reports. Like last week, they reported every week when they bring us additional information, we will be taking action about it. We must do that because we want the energy and the focus of this government and the people of our province to be on what the clinicians were presenting here, on COVID-19. How do we weather the storm? We are weathering the storm quite well now. We are not getting overwhelmed, but the storm seems it will be longer, more protracted than just passing quickly. And how do we prepare the healthcare system and bring in more resources, not just for now, but also for tomorrow? Because if corruption thrives, all those resources which would have been directed at enhancing our public health system would have gone to waste. So wherever things have gone wrong, when the investigations are concluded, there will be criminal charges. The money, recovering the money will be one of the clear intentions that we will pursue. Where it is business people and any government official, political or administrative, they will face the consequences. And this message must go out all the time. We are also now using the open tender system. Many people out there know the open tender system that we introduced in Gauteng in 2014 has worked extremely well. It has pushed back the scale of corruption because everybody could be able to see transparently when the adjudication of tenders is happening, who got the tender, why they got the tender, are they able to deliver? We know that during the period of COVID, the open tender system could not be implemented. So we immediately bringing back the open tender system. The second thing is that we will also monthly now, area of accountability and transparency is that every month we will publish any new tenders that have been adjudicated and awarded by any department in Gauteng. That's public information that must be known. Not just COVID, any tender awarded by any department. So on a monthly basis, our provincial treasury will make that info. That's the decision we made in our provincial cabinet yesterday. Our provincial treasury every month will publish a disclosure of tenders report. Together with the open tender system, reporting on tenders every month will also help us to ensure that we are held publicly accountable. If something has gone wrong, it is something that the public will be able to pick up there. Fighting corruption and ensuring that there's clean governance is something that we are absolutely committed. I have made this commitment to the people of our province. We introduced the open tender system that helped a great deal in helping us to achieve the results that out of the national audit by the Auditor General, the results over 5 years, we had improved tremendously our audit outcomes. But this period of COVID and the corruption that has happened here has discredited every effort we put in place over a sustained period of time. So essentially, we are forced to start afresh. This is a fresh start, and there must be consequences for where wrongdoing has happened. And there shall be consequences where wrongdoing has happened. And it must be for wrongdoing. It must not be fake news, where people who are innocent are being targeted for fake news so that the guilty and the corrupt will not be looked at. So that's important, and I want to emphasize that the focus in this province is going to be on continuing to weather the storm. The storm hasn't passed. It has just slowed down. We mustn't be complacent. We mustn't say we have overcome, not yet. The journey ahead is still there, and it may get tough at some point. We may experience the second wave. We must be ready. We must support all the work of our healthcare workers on the ground, our security services on the ground, our public servants who are honest, who are doing an honest job on the ground. We must support them, and we will support them. But the rogue elements must know their time to go to jail is now. And this far and no further. This far and no further. So, Thabo, I hand over back to you if there are any questions that are there to deal with.
All right, let's take questions. Can we see any hands here? The mics will come to you. No questions? Okay, let me check a few from the WhatsApp. Okay, I think there's one from Sisona from News 24. And the question is, now that we seem to be settling with the recovery rate, are there any talks about moving to level 2 and the unbanning of the sale of alcohol and cigarettes? These are matters that are being dealt with by the national government, as the Premier indicated earlier. The other question is from Zianda Ngobo from Newsroom Africa. And the question is for the Premier. And it says, Premier David Makura, is what suggestions and representations will he be making on behalf of the Gauteng Provincial Government regarding moving back to level 2 or easing lockdown to level 2? Again, the Premier did speak about that earlier, but he will make a brief comment about that. Are there any, this one is from Brumilda from Newswerk 24. Are there any new developments with regard to COVID-19 tender, fraud, corruption in the province? The Premier has just spoken about that. Khomotso Modise from Eyewitness News. You say Gauteng is ready to relax lockdown restrictions. Does that mean you want to move to level 2 or even level 1? Yeah, those are the questions that I have. I haven't missed any questions, Siko. Okay, all right.
Firstly, let me say that I don't want to preempt what the National Command Council will say and what the President is going to be briefing the premiers on when he meets with the premiers. We rely on evidence and data that comes from our modeling team. The emphasis that comes from there is that whatever you do has to be gradual. I think that both Bruce and Dr. Mary emphasized that everywhere in the world, we also follow developments where if things are not done that way, we may end up with a surge outside what the model says. The issue of schools, Emisili Sufi was here listening very, very carefully. Our Provincial Executive Committee endorses the recommendations of our advisory council that even when you deal with schools, everything must be dealt with. There must, because you make assumptions. If just one, the thing with modeling and the real dynamics, that if you lift one and then the other, it upsets the other balances. If you do something that is not done together with the others, you may find that thinking that the peak will be longer, flatter, and more protracted. The peak may just be shoot up because we have done something we were not supposed to do. So what we would caution basically is this issue around a gradual approach is important. In everything that gets done, gradual. It has been happening. You know, the risk-adjusted approach that national government has adopted about moving from one level to the other, it's an important thing. It's part of the gradual approach. The issue is that if you just move everything at once, we're going to be hit by a second wave much quicker than we thought, and it may even be much harder. The full implications of that is that whatever will be recommended, let me say to you that on the economy, I am very, very concerned, together with the Provincial Executive Council. So the provincial government is very concerned with regard to the state of the economy. So as we improve on the health side and add more measures to make sure we contain the pandemic, and we must contain the pandemic, we must also look at ensuring that the economy gets going. There is a relationship between the two. So whatever happens there in the economy, which is the key thing, I was addressing the legislature on Tuesday, and I said that this month of August, we are going to be paying a lot of attention to our plans on the economy, the revival of the economy, because the well-being of people, the health practitioners know, well-being has got many facets. If people who used to work no longer work, it has an impact on their mental health, depression. It has an impact on their ability to feed themselves and their families, nutritional immediate impact. So it has got far. So the issues around the economy are important also for health. So as we in managing the pandemic, I have no doubt that the critical discussion, so what is it that the Premier will be recommending? The critical discussion is also going to be, how do we ensure that we regenerate our economy, to ensure economic reconstruction and recovery, ensure we are able to bring back more people into work, but doing so in the context of what the clinicians were advising us on. As we do so, we need to make sure that these measures that have helped us to slow down the curve in this particular surge and flatten the curve, these measures should be in place. You may recall that one of the key concerns we had in June was what was happening in the mining sector. And the mining sector in this province contributed significantly to the surge. So are there lessons we can draw from that? So as we further open the economy, yes, I think from where we sit, we will continue to, if you want to know, I will recommend that we must, yes, continue to open the economy further, but this must be informed by the dynamics of various sectors and what can be put in those sectors to contain infections and ensure that they are not the source of the outbreak. They don't become the clusters for new outbreaks, especially for new hotspots. Because the story of the hotspots in this province, in many areas, they are also linked to sectors of the economy. The hotspots in the West Rand were linked to mining. The hotspots in Ekurhuleni and Joburg were linked to certain factories in those areas. The hotspots in Sidibeng are also linked to certain level of economic activity. Sometimes around the shopping malls, the supermarkets where there's no compliance. So that's very important. But I am saying I have no doubt that the issue of the opening the economy more will be firmly on the agenda, even from where we sit. Now there is a question about alcohol and tobacco. Now, I don't want to comment about alcohol and tobacco today. Let me give alcohol and tobacco a holiday. You know, I always speak, and I often ask the feedback from the clinicians. Before I deal with the question myself, I first ask what the health people's view would be on it. I don't want to ask them today. Prof. Laurel and Prof. Mlaus, I don't want to ask you. We had Prof. Muheng here, who spoke comprehensively about the impact of the earlier phase of opening the sale of alcohol was on the admissions in hospitals, and he gave that feedback about what the health workers are feeling. But where are we now? What will be the decision that will be taken? I must tell you also that, yes, there are also implications for the economy, implications for jobs. So I don't think we should think that there are people who don't worry about the jobs, and they are just worrying about the health, and then others who worry about the jobs. So all of us are worrying about the health of our people going through the pandemic, but we are also worried about the economy. We're also worried about the investments that should happen in the economy, the impact of the choices that have to be made are difficult choices. There are times when you must make difficult choices, like, given what's happening now, we've got to stop the sale of alcohol. And I must say, the feedback we have gotten after suspension, because it was not banning really, it was suspending. After that suspension, the hospitals were saying to us that it has helped. Is the burden on the beds, especially the critical, because some of the people who were getting admitted there, it's trauma, accidents, fights, shootings. It's the impact on the trauma beds was there. So whatever discussions will take place, I will say that the critical issue as a country we must face is balancing. We must find the balance between the health and well-being of our people and the need for us to succeed against COVID-19, containing it, saving more lives. This is one imperative. It's a very important imperative. We must do everything. And at the same time, we must ensure that we can bring back our children to school. We must ensure that people are able to go back to work. Those imperatives go together. There may be a period where one overrides the other because the numbers may be too high. And when the numbers improve and the surge is lower, we will re-look at that. But again, gradual, I think. The principle is gradual. So if you want to know what our approach to these issues would be, is that, yes, reopening gradually, continuing with the non-pharmaceutical interventions. That's social distancing, wearing masks, washing hands, sanitizing, but also continuing with taking the message to communities, using the model that was presented here about working at a community level where the facilities are. So Gauteng province strategy going forward is going to be that, which was presented here. We will ensure that we work with communities at a lower level with our healthcare workers, with our civil society groups, to contain the surge And when there is a new hotspot, we direct our resources to those hotspots. But we will also support opening the economy, continuing to do that in a gradual way. Any update on the investigations by the Special Investigation Unit? I think for the purpose of this week, the update we gave you last week was adequate. At the moment, they are doing further work, and when there is an additional update to make, we will. And I'm saying they are doing further work in everything that has to do with COVID. Not just PPE, infrastructure, food relief. They are doing that investigation. Anyone who's got information needs to know that that information needs to be brought to the Special Investigation Unit to help them investigate. Every procurement that was done during this period in dealing with COVID is under the spotlight. Thabo, I think I have answered all the questions. Thank you so much. We took longer today, but today was the time for the advisory council and the technical teams. Thank you so much for the work that they did. I think we are wiser. We will make decisions not just based on political whims, but that are based on science, based on technical input. Thank you so much.
Thank you. It's the end of the briefing.